All right, hello everybody. So I'm going to be getting started on the next unit that we're going to do. So I'll be doing these in small pieces. As you can see in front of you, here is the schedule. So we have drugs and bones for bones and joints, which will be gout. So I'll do a separate on gout and then another one on the calcium and bone mineralization, which is basically your osteoporosis. And then Unit 5 will be the respiratory tract drugs, which will be your asthma and rhinitis, which is allergies, coughs, colds, and that kind of thing. Then we'll do the content review day, and then you'll have your next exam. Things go so quick. So, all right, so let's get started on this PowerPoint. Let me get it up here. So this is Chapter 74, Drug Therapy of Gout. Let me get started. All right, so what is gout? Well, gout is basically a buildup of uric acid in the joint. It's a form of arthritis, and it's actually caused by purines in your diet that break down into uric acid. Well, what are purines, you probably ask? Purines are substances that are automatically formed in your body naturally, but also from diet, from eating a lot of meats, organ meats, red meat, that kind of thing. So people that have gout have to follow a diet that they really don't like because it's a lot of avoiding meat, because you can get that purine extra excretion that breaks down to uric acid, then deposits in the joints. There are some people that are more at risk for it than others. You should have had some pathophysiology already about gout, but if not, look that up and learn more about it. But usually, like, you'll see alcoholics, obesity, they're at increased risk for gout. But again, there's some people that just get gout and we don't know why. But if you can see here, they get it in the joints. So it's not a muscle thing. Again, it's another form of arthritis. It can build up in the joints, and most commonly it's in the great toe. So if you can see this picture of the swollen toe, and it's very, very, very painful. I would say almost equivalent to having a kidney stone. People have described it as, but that joint just becomes so full of uric acid crystals. And think of, crystals, how they're shaped, and really how that would feel being in a joint in your body. That would be very painful. It usually comes on real suddenly, so you'll see typically people wake up in the middle of the night with severe pain. They can't walk on it. And people that have chronic gout are either on preventative or know what to do to start the medication. So we'll go over medication to treat gout. So as I mentioned real briefly, that it is a recurrent inflammatory disorder. It's mainly seen in men. Rarely do we see it in women. But as you can see, this man here, he's an obese man. And so he's that risk factor. Now he's in a lot of pain. Do they wrap your foot up like that? No. But just to show how much pain that it causes. And if it starts in one joint, the great toe being the most common, then it's usually going to recur. Some people end up not having recurrence for a long time, but it's usually not the case. They can also happen in large joints. This is really severe. This is someone that's just had it not really treated very well and eventually diagnosed with gout. So this is pretty bad. If you have it in the great toe, you may be able to just treat it okay on an as-needed basis with a medication. But if you have it in the large joints, your ankles, your knees, which are very common, you want to be on a preventative therapy no matter what, even if it's just the first episode. So what is going to be first line? So what I want you to think about, and I always use that umbrella, gout is the top of the umbrella. And then underneath it we have abortive therapy, and then we have preventative therapy. So that's used for quite a bit of conditions. Such as migraines, what's going to get rid of your migraine right away and what's going to prevent another migraine. So this is similar with gout, what's going to treat the gout, flare-ups, and what's going to help prevent it from coming back. So right now we're talking about abortive therapy, meaning let's get this gone right away. So Nsaids, which you guys should know about Nsaids, right? So it's the agents of first choice. It's more tolerated and more predictable than colchicine. Now, colchicine is actually another first-line drug to help get rid of those uric acid crystals. Colchicine was given first. That was always first choice. But what we have found through the years is it's actually the dosing's changed. It used to be you take one every hour until you get diarrhea. Well, who wants to take one every hour until they get diarrhea? Then they changed the dosing, and there's a lot better medication out there called Colchicine, which is colchicine, but it's made a little bit different, so you're not going to see as many of the side effects or the kidney issues that you can see in the old colchicine drug. So underneath that umbrella, under the abortive, goes the Nsaids first, and then you can go to colchicine. But part of the Nsaids is indomethacin, naproxen, and diclofenac. Now, I know in the NSAID portion we did talk about naproxen and diclofenac, but indomethacin or indocin is another one that is under that category, that umbrella. So indomethacin is definitely more on the COX-1 side, whereas naproxen, diclofenac is more COX-1. Naproxen's a little bit of a mix of more evenly mix of both, I should say, but indomethacin has been around for forever and a day. It's got a lot of side effects. GI side effects is just huge with taking the indomethacin. So, anyways, but first choice: indomethacin, naproxen, or diclofenac. It's highly effective, and it's so highly effective that if they take the dose, then they usually start feeling better within 24 hours. The other choice that we can do, which you put under the abortive therapy, would be glucocorticoids, which we already talked about. So it should be a nice transition, because now you're seeing other things where these glucocorticoids are used. So again, this is like a super-powered anti-inflammatory, right? But more side effects, but it's very highly effective in relieving pain, and you're only taking it for short term, 7 days at the most. Sorry, I gotta turn on my fan. I'm sweating to death in here. Okay, so, and what this is really good for, patients who are hypersensitive to NSAIDs, or what if they already had a GI bleed, then probably giving indomethacin or naproxen is not a good idea to give that to them. Someone that has, cardiac risk factors, you may not want to give an NSAID to. And so a quick burst of steroids is really a good choice for a lot of patients. But just remember, the first line is the NSAID. You can give the colchicine or the glucocorticoid. So colchicine is another anti-inflammatory agent, no longer the first-line drug. Now, when you say colchicine, it's not an NSAID, so it does not fall into that NSAID category. It does not fall into the steroid category. It's just a separate category. It's an anti-inflammatory, and it's only used for gout, nothing else. And now it's really reserved for patients who are unresponsive or intolerant to the other agents. You can treat acute gouty attack, reduce the incidence of an attack, and abort an impending attack. So that's what it's used for. So there's some people that can use it for longer term, but when you're thinking about treating, think about colchicine as being a short-term drug just for abortive measures only. So what is the mechanism of action? So going through and trying to learn about the mechanism of action, scientists, researchers don't really even know exactly what happens, but we do know in some way it interrupts the cycle of the urate crystal deposition in your joint tissues. So while you have these uric acid crystals, which is urate, it's deposits in your joint tissues, but what this colchicine does is somehow chemically interrupts the cycle of the crystals from building up. And so then what happens is inflammation's reduced, and it helps get rid of that acute attack. There is some GI effects to it, some myopathy, muscle aches, and myelosuppression, bone marrow suppression. It is rare that that would happen, but you just know that that is a side effect to it. There are some drug interactions, but not a lot. Usually warfarin is one of them. For drug interactions, I should say. All right, so what are your goals of therapy for someone that comes in with hyperuricemia? Hyperuricemia, you have deposits of uric acid crystals in your joints, or one joint or two joints. So what's your goal of therapy? Well, you want to get rid of those extra crystals forming in your joints, right? Not only that, you don't want that to happen again, because someone who's in a lot of pain is like, I want this to go away and I don't ever want this to come back. So you want to prevent the disease progression, reduce the frequency, and improve your quality of life. All right, so now that we talked about the abortive therapy, let's go one step further now to the other side of the umbrella, and let's do some prevention. These are your prevention drug therapies. Allopurinol being the most common, Uloric, febuxostat, probenecid, and this Antarine, which is rarely prescribed. Probenecid is rarely prescribed. Uloric is now the mainstream one that you'll see out there. It is still brand name. It's not generic yet, because it has less side effects than allopurinol. Both of them work the same way, but remember when we talk about first and second generation, the Uloric is a second generation hyperuricemic drug, and therefore it has less side effects to it. It doesn't have that kidney. Of course, you have to watch for renal issues, but not as much as the allopurinol does. So they both do the same thing. So the first one, allopurinol, that's been around for as long as I can remember. Well, I'm not that old, right? But anyways, it's been around a long time. But it reduces blood levels of uric acid. So it's used for chronic gout. It's used for hyperuricemia, so buildup of uric acid from chemotherapy. As we know, chemotherapy can cause multiple side effects, immune system, and many things to multiple issues in your body, to multiple things in your body. Some adverse effects. Sometimes you get a hypersensitivity syndrome, GI effects, and neurologic effects. While Uloric does the same thing, it's a newer drug, but again, less common side effects. You have to watch liver function, nausea, joint pain, and rash, but it's for gout, and it is known to have, studies are showing that it's safer than the allopurinol. So both of these are the same thing, basically, but the febuxostat is just put together a little bit differently chemically. Now, probenecid's generic. It's been around a long time, and this actually works in the kidneys to inhibit the reabsorption of uric acid. So it helps to prevent the formation of new tophi, and it helps decrease the existing tophi. So when I say tophi, I probably should have told you before. Remember when you saw that those knees? That's tophi. When you see that that great toe, that's tophi that builds up. That's just the buildup of uric acid. So this prevents new tophi and helps the existing decrease. As well as this one reduces your blood levels, and it's used for chronic gout. Okay. And so I'm going to do a separate one on this one, so that'll be in something else. So, but what I want to go over here with the gout, I just want you to know, like, let's just say someone comes in and has a swollen ankle and they have a history of gout. How are you going to treat that patient? First line, you want to put them on an NSAID, or you can do, if that is not good for them, if they have a contraindication, or it's probably not the best because they've had, say, GI bleed in the past, you may want to choose some prednisone, a quick taper. Some patients have already taken colchicine for quite a few years. Remember, that's under your abortive therapy, because we want to be able to get rid of that. And the other brand name is Colchicine, which is your colchicine. So you can go ahead and say, all right, let's put you back on the colchicine. You've been tolerating it well. Because people that have gout that's chronic, they usually know what works for them. And they know what doesn't work for them. So they start that right away. But again, if you have it in a large joint, you want to go ahead and do some prevention with that. So that's when you're going to put them on allopurinol. And let's just say that they took some medication to reduce their attack, and they're doing okay, but you want to put them on a preventative. And I know this sounds kind of strange, but if you start them on allopurinol, sometimes it can promote a gouty attack. It can actually do the opposite. Instead of prevent, it can actually promote in the initial phase of it. So you want to put them on a colchicine just for a short time, about a week or two, until they get used to taking the allopurinol. Let's go back to allopurinol, because that's the one that's used the most, this one and the uroloric. And then after about a week, you can stop the colchicine, and then you can go ahead and they continue the allopurinol indefinitely. You want to watch your kidney function, you want to watch liver enzymes and that kind of thing, and all the other side effects that are listed. Okay, and that's it.